welcome to the Psychiatry and Psychotherapy podcast. I'm here to talk about getting rid of burnout, increasing job satisfaction, and feeling like an expert in what you do. One thing that created a lot of burnout and angst for me was trying to get continued medical education right at the last minute. So why not join the CME membership and see me while listening to this podcast? Go to psychiatrypodcast.com, sign up, sign in, take the test, and the certification is emailed to you in seconds. All right, welcome back to the podcast. Today I am joined with Dr. Stephen Hayes, some medical students, Matthew Hagley, Maddie Ulrich, Kyle Logan, Christopher Neal, who has graduated psychiatry residency and is doing a great job over there at the county. And today we are going to have a discussion with Dr. Stephen Hayes. He is the author of many of the seminal papers on relational frame theory and acceptance commitment therapy. He has written many books on acceptance commitment therapy. And this episode, we are going to be interviewing him and gleaning his pearls of knowledge. It's a great episode where we're going to talk about how he, would approach different topics. One including, how he would approach a therapist in training or psychiatrist in training who has a sense of imposter syndrome. And so I wanted to start out by just briefly going through some studies to kind of discuss what I could find evidence-wise when they compared acceptance commitment therapy to another active therapy. It's hard to just, look at the acceptance commitment therapy when it's standalone. The effect sizes are great, usually one standard deviation or more improvement in different domains, such as depression or anxiety. And I thought it would be interesting to find any study that I could that looked at CBT and acceptance commitment therapy when they do them, basically side by side. So this will be part of the introduction, kind of just talking about the efficacy of it. So CBT and ACT had equal efficacy for depression in the studies that I could find. A to Jack 2018 was a randomized controlled trial of 82 participants for MDD, and it showed that CBT had an effect size of 1.62, ACT an effect size of 1.17 for the quick inventory for depression symptomatology, and CBT was 1.19 and ACT 1 for the Hamilton Depression Rating Scale. So both had good improvement, and they put the between effect size favoring CBT, but did not have a significant p-value, so it could have happened by chance. And so they concluded that the treatment efficacy did not significantly differ between the two treatment outcomes. In another study, Tam and Nafsanef, 2014, in a randomized controlled trial of 19 women with major depressive disorder that did biweekly sessions of both ACT or cognitive therapy, they found that they both had significant reductions in depression, but there was no difference between the two in severity of depression or in the ruminative response scale. So both of them fared about the same in that study. In another study of 101 individuals with an average number of sessions of 15 for cognitive therapy and 15 for ACT, there was no significant difference among the treatment groups with depression, anxiety, or participant functioning. So all of the p-values were around 0.9 or 0.8. So in that study as well, they showed about equivalent efficacy. In terms of pain, we found one study where it was a randomized controlled trial of 114 participants with an average length of non-malignant chronic pain of 15 years, and they compared 8 weekly sessions of ACT or CBT, and there was no significant difference between the treatments in terms of a change in pain or depression. Both of them were efficacious. Of note, both improved pain measures even 6 months after treatment was done, and no significant difference was found between them. So this was kind of cool because it showed that, look, both of these work and they reduce pain with only 8 weekly sessions. That's not like a lot of weekly sessions. And these were people who had suffered for 15 years. When looking at substance abuse, ACT did better than CBT in the one study that I could find. So this was 50 incarcerated women with substance use disorder, and ACT was superior to CBT at post-treatment with 27.8% abstinence for the ACT group and 15.8% abstinence for the CBT group. Further, at follow-up, that percentage increased with 43.8% abstinence with the ACT group and 26% abstinence with the CBT group. They did not give effect sizes in this study. This was Lanza 2014. When looking at anxiety, I found mixed results when comparing CBT and ACT. In one randomized controlled trial, this is Wolitsky, Taylor et al. 2012. They looked at anxiety disorders over 12 sessions, and there was no significant difference between ACT and CBT treatment, except participants with comorbid mood disorders tended to have greater anxiety reduction with ACT at both time points, and this p-value was 0.07, but that's probably still good enough to point towards ACT being better. And those without comorbid mood disorders had a better response to CBT, but only at 12 months after treatment. So this study basically showed that they were equivalent with some minor superiority stuff with the ACT in terms of if the patients had comorbid mood disorders. So in another study of 128 people, this was Arch et al. 2012. In this study, they looked at people with one or more anxiety disorders, and they randomized them to 12 sessions of ACT or CBT. They concluded ACT and CBT did not differ significantly at post-treatment on either anxiety-specific or broader outcomes. Of note, ACT demonstrated a little faster improvement in clinical severity ratings, which I think is important. So basically, if you look at the curves, ACT seemed to make patients a little bit better faster than CBT. And the authors noted as well that at 12 months later, ACT was better than CBT. And they also noted that more ACT participants utilized outside psychotherapy during the initial follow-up. However, they also noted that if they took those people out of their analysis, they still showed improved rates of recovery 12 months after. So the people who had this ACT therapy, they continued to get better 12 months after the therapy was concluded. And another interesting sort of side note on this study was that CBT participants rated higher quality of life compared to those who went through the ACT training. The effect size was 0.43. This was Arch 2012. So I will put these all on the blog so that you guys can look at these articles. Once again, these are the articles that I could find comparing ACT to an active control arm, not just a wait list. And if you have other studies, let me know. I would love to see them. I think that there's a role for ACT, and there's things that we can learn. And I think that this conversation will show you just some of the kind of amazing things that Stephen Hayes has to offer the psychotherapy community. I took away some things, some knowledge. I was blessed by it. I did some role playing, and he played the therapist, and it was a lot of fun. So hopefully you can gain some insights into ACT and to the theory and to the model and how it helps and how it practically can be played out. So yeah, maybe let's start. Should I call you Dr. Hayes? Is that how you like to be referred, or?
Steve actually works. Hey, you will get my attention.
So you're out there in Nevada, and COVID season has not been a fun season, right? Because you've been stuck probably without.
We have been. I've hardly moved outside since March.
How many trainings a year do you usually give, like around the world?
Oh, usually a couple times a month. But what's happened is it's actually gone up because of COVID, not down, because everybody in the universe now can reach out and say, hey, it's just an hour. Yeah, but you do understand I get 5 a day, so.
Oh my gosh.
It really, I'm exaggerating, but
wow.
I probably get 2 a day. And, you just can't do that. So, but it's good. I mean, World ACT is a worldwide thing. And fortunately, there's a large community. Although I did originate it, I say I'm the co-developer, which is true because there's so many people who have hands in the work. And so they don't necessarily need the old bald guy to get good ACT training.
Yeah. So tell me a little bit about the history of how it formed and what kind of maybe the simple explanation for how this is unique compared to other types of therapies.
Well, it's been on a 40-year development. You're talking to an old man. The first ACT workshop I did was in 1982. So coming up on 40 years. It emerged out of my own panic disorder history and hitting bottom and then realizing that some of the things I learned on Hippie Hill, I mean, I'm an old a hipster and so forth. I'm more kind of Eastern things had more traction than the things I was being taught. I was raised in behavior therapy and CBT, but with interests in many forms of psychology, actually more humanistic forms of psychology got me into the field. And I was just thought that was odd, that why, mindfulness work, I guess you'd call it now. Back then, the M word was hardly used. And I'd lived on a commune, a religious commune, and I knew that the M word had been a source of great conflict. I mean, monks have been hitting themselves over the head about the definition of it. And so it was the last place I wanted to take evidence-based work. But because of that personal experience and the kind of shock of that I quickly turned in a different direction after a 3-year spin into panic disorder. And remember, this is before John Kabat-Zinn. This is before mindfulness-based cognitive therapy. This just seemed nuts. I mean, especially for a behaviorist like me. But I said, I got to figure out why this thing has so much traction. So we did 3 randomized trials, only published one of them. The other ones we dribbled out later. They all worked, but I didn't want to get out there and say, hey, this is this great thing, because I didn't understand it. And I spent 16, 17 years in relative obscurity. Almost no one knew what we were doing. Working out the model, the processes, the measures, the components, even the philosophy of science. I thought that was so critical. How to walk into the lion's den of, languaging about language. That's tricky. And we ended up at the end of that arc with a new theory of language and cognition of the human mind, which has a life of its own in the basement. People who come into the ACT world, they gradually hear about it and eventually get interested in it. But, we can do things there, like take, let's say, children who don't have a sense of self or on the spectrum, for example, and kind of bring them into a more normal sense of consciousness, or raise IQ, or help kids who don't know how to language at all do that. We can teach language skills to kids and kind of rescue them from a life of disability. Pretty cool stuff. But all that happened in that era, and we worked out the underlying model. So where we are right now, after a 40-year arc, and now 411 randomized trials and about 3,000 to 4,000 to 5,000, depending on where you do the cutoffs, studies on the processes, the components, and the basic science. I can sit here and say, what we have done, what we're bringing to the therapy world, is kind of a hack of the human mind, number one, and then turning that into principles or processes that you can use. Yes, in mental health, but also behavioral health, but not just that, high performance sports, prejudice, stigma, social problems of all kinds. And you can take that kind of hack, turn it into 6 basic processes that are all really one thing, 6 aspects of one thing that do more in more areas than any other set of processes known in science. Excuse me for the self-praise, but because of the arc of the development, we're here, I think, with a really powerful set of change processes that apply to the relationship and apply to psychoanalytic psychotherapy or humanistic psychotherapy or whatever, because it's really not a therapy method. It's a model of how the human mind works and how that clashes up with learning processes that are 1,000 times older and with basic biological processes that are even older than that. And so That's what I represent, and I care more about the model and the processes than the techniques and methods, and certainly not the packages, names, trademarks. All, please, oh please. So there's probably 30 different names for ACT. People tweak it and rename it, and that's all fine.
Yeah,
but it's turned into a pretty central part, I think, of modern evidence-based psychotherapy, especially in the CBT wing. But it's increasingly being viewed by humanistic folks, analytic folks, systems people, and so forth as being of importance.
Yeah. So first came like relational frame theory, right? That was kind of the first sort of undercore.
It was as the sort of rollout in this way. I mean, really first came, what's this happening here? Because I really had a transformational moment. I'd done a TEDx talk on it. I might call it my night on the carpet, where I hit bottom inside my panic disorder. And somehow or another in there, in the desperation, there's no way out, learning by its result, but leaping into a fundamentally different idea, which is I needed to go in instead of go out. I needed to open up and embrace and feel and sense what anxiety was like and what my mind was doing, and to really notice it. And there was the kind of the click out was a sense of separation, almost an out-of-body experience of noticing that you're talking to yourself all the time. You have this voice that seems like you, and no, it isn't you. It's just a repertoire. It has life of its own. It's happening when you're sleeping. It's full of all kinds of crap and prejudice things, crazy stuff. Anything you've ever been taught, said to, talked to, remembered, it's rumbling around there somewhere. And this kind of sense of separation between the observer and the observed, and that we're connected. I'm in consciousness. I'm aware of it, but I don't have to be dictated to by it. So really, I would say first was the personal experience, then the sort of roughing out of some methods to help clients, finding out very quickly within a month of that moment, I was doing that kind of work with my clients. I was trying to walk them into, first quite crudely, what had happened to me, and noticing that things move way faster and lives opened up in ways that didn't look like what I used to be doing in psychotherapy. And then as I systemized that and started getting measures, about a year in, meanwhile, I'm really trying to push why. My lab was full of clinical students, we called it the basic slide. It was just 5 students, but we slid all the way down to things like, what is a word? I mean, it was down to that, like, what does meaning mean? Okay. And then coming up with an answer to that was brand new on the planet. And that I think long run, if somebody's looking at this film, if they still care about it 50 years from now and I'm in the ground, my prediction is RFT is a lot more important than ACT. Because we think we have a different way in, an evolutionarily sensible, evidence-based way in as to what was the pivot point between us as human beings and what the bird is doing outside the window. And I come out of the animal learning tradition. And a lot of those folks believe there is no pivot point. It's just complexity. That's it. No, it isn't. There's something new. We're doing something really brand new. And yeah, it drove brain size, but it's not due to brain size. Why would the brain suddenly get big? Doesn't make any sense. It was driven by the basic kind of neurological need to do this incredibly complex thing we're doing with the human mind, where we can relate. I've actually done the math. I'll explain it if you get interested in it, but we can relate more things to other things than there are molecules in the universe with what's in between our ears. And that takes a little bit of calorie usage and a head almost too big to get out of the birth canal. I mean, it does take that. But so RFT sort of started coming in. 1982 was the first ACT workshop. 1983, I'm talking about RFT. And so boom, boom, boom. And now, many years later, here we are with about 10,000 people in the main society that develops this in 28 chapters around the world. So, yeah, it's a thing. Overnight success. It took 4 years.
Yeah, it took 40 years. Oh, that's usually the, it's like you're in the research and then there's a process of actually telling people about it, right? And so it's good
and
to have you
developing
on.
and learning and new things. And, ACT is
Yeah.
one reason I won't say I developed ACT is that these things that come in keep moving it forward. And so, the centrality of things like compassion, or this process-based therapy adventure I'm on with my colleague, Stefan Hoffman, another thing of sort of really radically moving away from packages and protocols to processes linked to procedures on an ideographic basis with the needs of an individual client. Now, all these things are kind of roll out because people have better ideas than I had, and I'm only too happy to steal them.
I'm still thinking that the audience is probably like, what is like relational frame theory, right? Matthew, let's have you read one of this quote from your 2005 article with Fletcher.
Sure. This was helpful, at least in my understanding. Quote, a simple referential relation between a noun and object is bidirectional and mutual for normal human beings. RFT theorists have provided an increasingly large set of data showing that this process is learned and extends to every imaginable type of verbal relation: opposition, difference, hierarchy, temporal, deictic, and evaluative, and comparative relations, among many others.
Okay. Dr. Hayes, can you break that down? Like, what does this really mean?
Okay, so here's the deal. We've tried for 300 years to understand the mind based on association. If you just go in there, mainstream cognitive science, etc., it's either the neurobiological connections as sort of physical metaphor for association, or a psychological sense in which this is somehow connected to that because they co-occurred together. It's not how the mind works. The way that what happened is that our basic capacity to learn by consequences, operant conditioning, which has started in the Cambrian period. We know that because every species that evolved since then does it. None that before do it. That means it's 545 million years old. That you can learn by consequences and by association, classical conditioning at the same time. Habituation, a little earlier. And since then, basically nothing new. I mean, the bird outside the window, that's the way they're learning. So we have your basic biology, you have that learning process. What we did, because we're such a cooperative species, and we already had the beginnings of social referencing, theory of mind, understanding intentionality, cooperation came first because we're the tribal primates, where cooperation is why we took over the planet. Mm-hmm. Within the band and tribe, mind you, lots of wars between them. Mm-hmm. And with suppression of selfishness. So you do those two things, higher level cooperation works. You suppress lower things can happen. Eukaryotic cells can happen. Mitochondria can make a deal with a nucleated cell, and woohoo, it's a different life form, but we'll work together. It's 600 million years old, and pretty good cooperative system, except every once in a while mitochondria cheats and makes plants only produce by the maternal line so it can pass on its own genes. How many cells you got in your body? Trillions. Any one decides, hey, I want more of me, you got cancer. Mm-hmm. But you suppress that. This cooperative thing we're doing called language happened, I believe, because while many, many animals can name objects, hooting away when they see a snake, or, call out a call when they see an eagle, and run when they hear it, but it's not coordinated. We get to do things like, this is a cup, to a baby, and then you say cup, and the baby orients towards the cup without being trained. But that started, I think, because cooperation fed it. If you understand the intentionality of it, if you had a name for an object and you've got a hominin on the other side of a ravine and you can say what it is, apple, or whatever the name was back then, you might be brought an apple. That would massively expand cooperation, make your troops so much more powerful.
Yep.
Yeah, but once you can do that, you learn it in one direction, derive it in two, and there's no other species on the planet that does that simple thing. That's the smoking gun. You give a name to an object and then say the name to orient it towards the object. The language-trained chimps, I'm here in Washoe County, Washoe the chimp. That's Alan and Trixie Gardner at my department. And the sign language chimps, when they tested it, in Atlanta, for example, with Sue Savage and Dwayne Rumbaugh's chimps, chance level responding. Chance level. And these are chimps who've had massive amount of so-called language training. So, but your 12-month-old baby will do it. But once they do that, here's what happens just a few months later. Oh, look at the nice metronome. Baby's never heard that, looks around, sees an unfamiliar object, derives the relation. That unfamiliar name goes with that unfamiliar object. They'll even start calling it if they can. Well, metronome is too complicated for a baby, but if it's simple enough, they'll start giving it a name. So you get same, then you get different. Then you get comparison. This is better than that. Then you get I, you. What do I have? What do you have? And on it goes. Hierarchy. This is part of. This is so. There's a ditty for this. You learn it in one direction, you derive it in two, you put it in networks that change what you do. That's the human mind. Now, here's the deal. Here's why this matters. In addition to the fact you can train it with kids who don't have that, you can establish a sense of self when you understand what the bidirectional relations are that give a sense of self. And we think we know that. They're I, you, here, there, now, then. Those big three, time, place, and person, basically. Perspective taking relations. What happens is we now have this massive generativity. If you had 8 events and 8 words that went with events in 8 possible different ways, you can derive 4,000 relations. 8 to 8 with 8 different connections, 4,000 relations. Just do the math. How many things you got in your head that you can relate to other things? Well, I'll tell you what, let's just look around. I've got a chapstick, I got a cup. I'll come up with a relation that's just not very familiar. Father of. You got to tell me, how is a chapstick the father of a cup? If you don't, this thing's ending. I'm saying goodbye. No podcast. You got to come up with an answer. How's a chapstick the father of a cup?
Well, if you don't have chapstick, your lips may get too chapped drinking, and so you wouldn't drink from something that you got too chapped from.
Awesome. That's very, very good.
I don't know. What would you say?
Well, that works. It's worked. It's apt. It kind of fits. If I was designing the cup, maybe and I didn't have a pen, I could draw it with chapstick. There's others. There's probably, well, how many answers could you get? A father, you probably could get 100 if you had enough time. Ask your med students there. They're going to come up with some. They've already got some good ones. Flip it around the other way. How's the cup the father of a chapstick?
Because you burned your lips and you need the chapstick now.
There you go. Woohoo! The thought that came to my mind is I'm going to go to the store, but I don't have enough room to carry all the chapsticks. I'll take my cup and I'll put them in there, and then that'll maybe bring the chapstick home. And when you do that, it looks like it's apt, right? It's based on the actual formal properties. Cups are really like that. You really do burn your lips. It really does help. It's real. It's real. It's not an arbitrary relation. It's in the real things. Here's the problem. Any two things will relate in any possible way, in an apt way that will apparently be based on the formal properties of the related events. So either God arranged the universe where everything is related to everything else in all possible ways, or this is an illusion of mind, which is what it is. It's an illusion of mind. But now here's what this means. We can relate to anything else in any possible way, all right? This thing is happening in your sleep. And you think you're going to help people think more rationally? You're going to help them like clean up their little cognitive ecology when they've had, parents saying things to them like, you ruined my life. That'll be in their head forever. And it relates to everything. So, if you don't know how to back out of the human mind and just watch it, and take what's useful and use the rest. Take what's useful and leave the rest. You are in absolute desperate straits. So yeah, we can use it to imagine a universe that's never been. We can do incredibly creative things, but we can imagine how life will be better when we're dead. We can imagine how, we're so successful, but we should have been so much more successful. You can suffer because you have so much money that you can't trust people. You can suffer because you're so beautiful. How can you? Anything can be turned into anything.
Yeah.
Get it? Well, that means we've got to rethink how are we going to rein this in, put it on a leash, use it when it's useful, when inventing and creating and things like that, but find a center where there's more to us than that. And so the hack leads to methods about reining in the mind, finding a sense of self in which you can do that, using it strategically to open up to your own history, coming into the present moment where things can happen, focus on your values so you know the qualities of what you're trying to produce, and then get your behavior organized around that. And those are the 6 flexibility processes. I said them in a way you can't chop them into 6, but play back the tape, they're in there. And it's just the way that the human system evolves. You get the flexibility from emotional and cognitive openness. You get the context sensitivity from focusing on the now consciously. And you get the selection and retention processes from values put into action. Mm-hmm. And variation, selection, retention, and context, that's evolution, dude. That's how it works. And so we evolve human lives. That's what we do as therapists.
Neil, go for it, and then I'll tell you what I was going to say.
Yeah, for me, this relational underpinning, although I still probably don't fully understand it, is initially what drew me into looking at this. My pre-med school graduate work involved some historical linguistics, and then I dabbled in functional linguistics. And so when I started to see the underpinnings for this, as I was realizing I was going to go into psychiatry later in med school and wanted to start learning some psychotherapeutic techniques, this made sense to me. And as I read a little bit about RFT, and it has its own kind of practical applications, and Dr. Hayes might talk about that. I know perspective shifting is a big one that's been important. People, we have friends with autistic kids, and you know, learning that has its own practical applications without even going, you know, fully into ACT. But then I learned about the 6 core processes of ACT, and of course that learning something that I could use in I could apply one of the processes where a patient is the most stuck. It's not a linear manualized approach. I could see, I could shift and move. And when I saw that, I realized this is something I could use in a 30-minute med management appointment. I could use it in an initial evaluation. I could use it with myself and friends, family, and coworkers, and all of that stuff, because there's no point at which any one of us is completely flexible at all times. And so for me, this is what initially drew me in. I don't know if you want to speak to any of those points.
Yeah, they're awesome points. And I usually don't lead with RFT because it's geeky and it looks like it doesn't immediately land. We actually I wrote a whole book with Matthew Villette and Jennifer Villette called Mastering the Clinical Conversation, just talking about how even the words that you choose and how you talk to your clients are already modifying the relational networks in which they live. And that I was determined to write this book without ever putting action in it. We just as almost like an exercise, and now it leads so easily to very acty kind of interventions. But we just wanted to show that even just the basic cognitive principles will help. But these more middle level terms of acceptance, diffusion, flexible attention to the now, perspective taking, sense of self, values, and committed action. Those are the 6. You can put them into little pillars: learning how to be more open, learning how to be more aware, learning how to be more actively engaged. You can put it into one thing: psychological flexibility. And when you measure them, they all hang out together. They hang out together because evolutionary processes have inherent features to them: variation, selection, retention, and context. That's how it works. So they hang out together because they play off each other. It's like 6 sides of a box. When you put it together, it makes a strong box. If you disconnect 2 or 3 of the sides, it's not a box anymore. And in the same sense, these processes are not independent. They're features of a complex system that have certain characteristics. But that creating these more middle level terms of acceptance, diffusion, and so forth allows you to have kind of a third eye when you're meeting with your clients. And you can see them right in front of you get entangled with a thought, or avoidant of a bodily sensation or emotion, or not being here, or being able to take the perspective of others, or not being focused on really what's of importance in terms of not just goals, but the qualities of their moments, and not be able to mobilize their behavioral resources towards it. And all psychotherapies mess around with these processes. What we're learning when we look at the mediational analysis, you actually look at what are the functionally important pathways of change inside randomized trials. I just, with my colleagues, Joe Sorochi and Stefan Hoffman, have reviewed every single mediational study ever done in the history of the universe on psychotherapy. We haven't yet put it out, but we looked at 55,145 studies. Took us 2.5 years and 50 people working on it. And I'm giving a talk here later in December at the Evolution of Psychotherapy a conference called Why People Change, where I'm going to just say, okay, here's everything we know about processes of change that are vetted by how most scientists are trying to vet processes now, or through mediational analysis. And the psychological flexibility ones, if you get a little friendly about people talking about these things in different ways, sucks up about half of what we know about how psychotherapy works. And there's other ones that kind of relate, and it depends on how open you get, like, is anxiety sensitivity really about emotional avoidance, for example? But so I think we're on a cusp of something where we can simplify therapist tasks massively and get out of these packages and schools and all the rest of it. And in an idiographic way, person by person, personalized medicine. What is this person doing psychologically? What are the processes that they're feeding, and what do we need to put into the system to perturbate it, and then to have it stabilize in a more healthy thing where over time things get better instead of over time things get worse. And that would be a really awesome vision of evidence-based psychiatry and psychology, instead of syndromes and protocols. We go to collections of processes and procedures that move them. And in successful personalized medicine, that's how it works. I mean, what are the actual things that are going on that you need to correct with that particular person? And if you have a disease entity and you know something about the etiology, course, and response to treatment, you have some of those functional units. When all you have is syndromes, you don't. You just have topographies. And so we can go to what now 40, 50 years of evidence-based psychotherapy tells us. We have outcomes, we have procedures and packages, but we also have a lot of mediational evidence. We have a lot of knowledge about processes of change. What would happen if we go there? Because those processes we know link to outcomes. We don't know if the 5 out of 9 or the 4 out of 7s link to outcomes. We don't. We're just going by topographies with the signs and symptoms that are inside our traditional diagnostic system. So it's an exciting time that goes way beyond ACT. ACT is just one of the first and one of the best because we've been at it so long. But I think the whole field's going to move in this direction.
Now I have an example, and I'll share it, and you can break it down and use it as maybe a way to talk more about the processes, and feel free to critique. I'm open. But, I did one of the trainings with you in Vegas, and you had done this exercise where you showed slides on the screen, but only one person could see that. And we were practicing doing all the processes at once and how they interact, and being flexible and kind of rapid changing. And you have a coach and all that. And that's an interesting model that you used. I think it's called the Portland Group Model. I've talked a couple of residency programs about trying to implement that in their training. Yeah. But the outcome of that was shortly after that training, I was at this was not a client or a patient. This was a friend of my wife, and she knew what I did, and definitely wanted some help. And this person had 2 years before had experienced the death of her 3-year-old daughter.
Wow.
And she said, Neil, I'm stuck. I keep getting stuck. I keep coming back to the vision of her dying. And I wasn't involved in their life at that time, so I actually don't know the cause of death. And I don't know that they know completely either. But at the time of the death, this little girl was either seizing just before death, or, something like that. But it was very visually disturbing to the mom who was there. And she said, I just need to get rid of this. I need to get rid of this pain. I need to get rid of this moment. I want to not be able to remember this ever. Can you help me get rid of the pain? And I realized after that training, I was able to identify there was some fusion there. She was kind of stuck on this idea of this event is painful. There was some avoidance. I want out of the moment instead of acceptance. Right. There was some self as context issues going on with seeing herself as defined by this moment, and a kind of a bad mom because she couldn't save her child in that moment. And of course she was in I think they were in Loma Linda Hospital, so they were surrounded by specialists and experts that were not able to save the child. And they knew that the dying was happening. There was loss of contact with the present moment. And so you talk about in one of your more recent books, this idea of pivot and finding the point of being stuck and literally flipping it on its head. And this is what I said, for right or wrong in the moment, this is what I said to her. I said, I would never take that pain away from you.
Yeah.
Because you are only seeing it from your perspective. You're looking down at your daughter, and your daughter's dying, and you want out of that pain. But I want you to flip it around and see it from your daughter's perspective. Your daughter looked up, and at her worst moment in her life, saw her mom loving for her, being there for her, and caring for her.
Wow.
And you would not exchange that pain for anything because you were there. Do you know how many patients I have that do not have a mom like you?
Wow.
And she cried. I almost cried. People listening were crying. Like, it completely transformed her definition of the experience. Did it solve all of her pain and grief? No. But she will tell people, I think, to this day, that was a very helpful process for her. And I caught it in the moment because I've done some reading. I've been practicing this stuff for a few years now to see that she was truly stuck, and she needed your words, not mine, a pivot to move forward in multiple processes at the same time.
It's an awesome intervention, awesome example. I mean, and she was very lucky to have you be the one to hear that story, because, love and loss is one thing, not two. And the pain she was feeling was a reflection of her love for her daughter. Yeah. And
what moves me about that story is it's like the narrative that she had before was, I'm in this pain. This is a great loss. And the narrative was taken out, expressed to you. She was feeling the deep loss, the deep sadness. You validated it. Empathy, right? And then you also inserted in another aspect of the narrative, which was also true, right? This aspect of the narrative that the daughter was comforted by her presence, and she hadn't thought about that, and so that gets inserted into this memory, this very painful memory now, and that changes the overarching experience from potentially being something just purely traumatic, where she wants to dissociate away from it, right, to something where it's that's a beautiful moment.
I think that goes back to what you were saying about language too, how she decided to make the connection that it was a moment of suffering for her and pain, but when you take it from the daughter's perspective, you can write a totally different story about the same event, how it was a moment of comfort and love in her last moments.
And I even ended on a values statement. I didn't mention that earlier, but I said, would you take this event away from yourself knowing that this is the kind of mom you wanted to be? So I was able to reconnect it at the end to values, hoping that in the future, as it comes back up, as it will, that she will realize it was important enough to her to stay with the pain and not continue to want to get away from it. And she, of course, I knew her well enough to know this was one of her core values. And so there's so many other processes that were involved there, but and that's why I think it stuck out to me, in part because it happened shortly after the training, in part because it's a very emotional and very memorable story.
It's a beautiful piece of work, and these kind of moves, what you're able to do is a concept in the relational frame theory called transformation of stimulus functions, where we're the meaning-making species. We're constantly giving meaning to what happens to us. We're fitting it into a narrative. And while you can't control this wild horse of language, you can use it to serve your own purposes. When you connect with the kind of person you want to be and what your values are, that perspective-taking move, which connects you to this more spiritual witnessing self part of you, from which the hell of your own history is not a threat to you, and you can see options in the moment. I think what you helped her to do is to see, you could say reframe, but it's not, if you did it in any way of, oh, well, that's just, or in any way dismissively or manipulatively or something, it would not have worked. You have to go deeply into the experience itself.
Yeah.
And in there, see that there's a deeper meaning here. This is what a loving mom does in a moment like that. And it impacts those around her, including her child who's dying.
Yeah.
So you're actually serving your child. And it's a beautiful example, Neil. Thank you for that.
Yeah.
Awesome.
I also think I think that was a really good point, Dr. Hayes, where you talk about it's Neil's presence. Is Neil really feeling this? It's Neil's empathy that allowed that to be something that was actually functional. It's not just a trick. It's not just a psychological, let's look at the silver lining of this horrible thing. It's Neil is inserted into that memory. He's suffering with her. I felt her suffering from you even telling it. So I know that you were suffering even hearing it.
I imagine the audience was tearing up hearing it. I certainly was. But, now look at these same processes as applies to you in that moment. Because you're hearing this very painful thing from somebody that you care about. Yeah. And for you to step in there in that bold way required you to feel, and required a little bit of perspective taking on your part. What is it like to be her? Probably anyone beginning to hear that story think, what would, if that happened to me, if it was my, and you're willing to go there. Your values of stepping in there and saying some things that are bold, and you're not sure how they're going to land, but they seem apt, they seem real, they seem true to your own experience and to hers. And so, I don't think it's that complicated. I think we actually know these moves. We know it's healthier to be whole, to feel, to see, to care about, to take perspective. We know that, but we can easily get into the problem-solving mode of mind, which is trying to diminish and eliminate instead of empowering us to be here now as whole human beings. And so if you couldn't have done that, if you were trying to avoid, you couldn't have done it. You would have tried to find a way to minimize or diminish in order to manipulate yourself. And in so doing, you wouldn't serve her.
Right. Yep.
Well, and for the number of psychiatrists that are listening, it's not all psychiatrists listening to this podcast, but a number of people are interested in it. And, we learn, quite frankly, we learn the exact opposite processes. We learn, solve this problem, move away, take this, medication to remove, and act as a evidence-based way of giving another option for dealing with these. And they do work. They are natural once you realize, I think, what they are. That doesn't mean they're always easy to apply, but they are there, and they're there for us as well. We are involved in the process. I actually, at this moment, I can laugh about it now, but I couldn't always. I was out for a run on New Year's Day, and an elderly gentleman lost control of his car and came up on the sidewalk and just a few inches away from killing me, ended up with a compound fracture and emergency surgery. And as I was recovering in the rehab hospital, I was finding myself having to learn to be flexible and practice my acceptance processes and not solve the problem of how fast can I get back to work and how fast can I get off these pain meds and all of this stuff, and literally trying to see myself, well, quite frankly, from the perspective of the driver who hit me. And how scared he must have been losing control of his car. This was not an intentional act, but he lost control of the car. We actually made eye contact before he hit me, and just shifting back and forth between that and not trying to solve the problem, but sit with it. And honestly, the most helpful thing I did emotionally while I was in rehab hospital was using some of these processes myself.
Well, and we have pretty good data in rehab and walking through injury and recovering post-operatively and opiate use. And, the psychological flexibility literature is vast. We have pretty good evidence that when people are able to walk through rehab in a way that is healthy, they use some of these same processes. And they're in our culture. They're kind of but we can put them more into our patients' skill set and reap some benefits from it. So, yeah, there is that same message. One of the cool things about this focus on process is the things you learn over here apply over there, because this skill set is applicable to almost any kind of psychological challenge. And so why not go to the kind of gatekeeper moments, whether it's a physical injury or a relationship loss, the death of somebody close to you, some sort of, a panic attack. Thank God for my panic disorder, man. I mean, you would not want to be around me if it hadn't happened. I was just crazy driven, get my vita, get that grant, get that, and part of me said, no, I'm just not going to let you do that. And thank God for that, because it gave me another way to move forward. And the grants still came and the vita still built, but I didn't have to objectify and dehumanize myself and treat myself as a horse to be whipped, as I think a lot of people do inside. We found that the psychological flexibility processes will relate to how successful you're going to be at business, how good of a therapist you're going to be, how much stress are you going to burn out. I mean, so I don't want to make it seem like it's one size fits all. You have to figure out a way to put these in the situation. But one awesome thing is that the processes change first, the outcomes come second. If you learn the processes and learn how to read them, you can come out of a session with a gut sense of, I just did something important. Because you can see the change immediately in front of you. You can see that little opening to an emotion that was previously run from, or that little stepping back from a thought that was entangling, or that little connection to something that's really of importance, or those perspective-taking skills. You can feel them in yourself. You can see it in your clients, and you can rely on them. You can trust them that when those things happen, you're doing something useful. So it gives you a guide almost session by session. Your patients become your teachers.
We're just, before this episode's coming out, we're going to be launching an episode on openness with Maddie here. And we looked at, one of the big 5 traits of openness. And first of all, I would estimate, Dr. Hayes, your openness level is probably at least 2 standard deviations above the mean.
From just talk to my wife.
What's that?
You have to talk to my wife.
Oh, okay. But I would also say we just did an episode on conscientiousness, and your achievement striving is probably 2 standard deviations above the mean, just like Neil and mine as well. but it's probably been tampered by your sort of psychological growth is what I'm hearing from you. Just like what are your values? Things that you will not sacrifice, right, at the altar of achievement striving, so to say.
Well, in almost any domain of life, you go in and you say, just Google it. Take like parenting. Go to Google Scholar, put in parenting and psychological flexibility. It just, and you're going to find there's hundreds of things out there. I mean, people are onto it in almost any domain of life, whether it's running a business or learning something or being a good parent there was just a meta-analysis came out yesterday with relationships and with being a good parent, that combination, with 43,000 participants in 133 studies. And there it is, psychological flexibility. So, learning how to be more flexible will just pay dividends for you. And it's worth the time and attention because it's applicable in so many ways. If I could tell a story, that transition doesn't necessarily come automatically. In A Liberated Mind, this trade book that I wrote that summarizes the whole literature, this recent book that just came out, I tell the story of developing tinnitus or tinnitus. I'm never sure how to pronounce it. People pronounce it 2 different ways, but I'm an old punk rocker. Not a good idea to stand in front of 50-foot tall speakers from people who are, singing like aircraft engines, because then you get to be 72 years old like I am. You're nothing but ringing ears. And when it first started really showing up, I was like, oh, make it go away. What's it? Oh, I hate this. And then I had the thought, I'll just shoot myself and then the noise will go away. And this other voice comes and says, dude, that's a suicidal thought. Maybe you should apply your life's work to this.
Oh, yeah.
It took me 3 years. And I went out for a walk. I came back. It was like 60% handled by the next day. It was 80% handled by the next day. It was gone.
Oh.
We've now done randomized trials. It wasn't gone like the noise is gone. What was gone is the disruption.
Yep.
I never noticed it anymore. Why? I don't attend to it. I'm noticing it now because I'm talking about it. But my point being, when you have a skill set, you may not be so smart to necessarily apply it everywhere, 100%. But they do transfer over. And so why not take what Western science gives us of these simple sets? And there's more we can add to it. It's not everything. It's not all of psychological knowledge. It's not all of therapy. It's not. But it's a good start. And when you do see how it lands, stories like this awesome story Neil just told become possible and easier.
So with your tinnitus, first of all, I've had a couple patients with that as well. And they can be so monolithically focused on it. And often the rage and the attached to the narratives, with a couple of them, like vets that I had, patients, the narratives were the great injustices of the war, of having to harm children in one story, and having to, leave their family and have their girlfriend go on with another guy. So all these stories get attached to that sound. I'm wondering if that's kind of what you're talking about. There was some sort of other alternative narrative that was attached to it that you had to disconnect.
Well, there was a little piece of how stupid could I be to, be, part of that music scene. And I look at these kids walking around with their earphones from their smartphones, and I know how cranked up that music is. And I'm thinking, you just wait, when you get my age, you're going to have an issue. But yeah, there was a narrative piece in there more around my stupidity of not taking care of myself. It's not like anybody would not know that it's unwise to.
But it's hard, and it's hard to be so self-critical of yourself, for something that is, a noise that's just ongoing. That you're critiquing your younger self for making choices, and it's hard to sit with that.
Yeah. Well, these narratives pull us into in the fusion piece. What RFT says, what drives these relational networks and makes them rigid is coherence. They fit together. They make sense, but they become a gravitational force, which is why schemas happen. You have these narratives and if you have a paranoid narrative, let's say if you're inside if you had a psychotic break or something, it becomes gravitational. It starts sucking so many things to it. Everything starts making sense in terms of it. And so it becomes its own life form almost. It's like a virus or something. And so diffusion is this matter of not directly trying to contradict it, that just sort of amplifies your focus on it. But of finding a way to step back, notice, but also diminish the unhelpful impact. Use it when it's useful, leave it when it's not. And that kind of allows a softer narrative to come in. And often you can find new narratives that work a lot better. Like I would guess, Neil, that there's a new narrative inside that mother about what her pain means. It's in a different network. It's still there. You could repeat it. You could even remember it. You could tell the story, but it's now has different functions. It's part of.
Yeah, I think so. I think she would say that. I think she has said it to other people that there's a new way of looking at it. And you have to she probably has to repeat the work from time to time, or maybe she comes up with better stuff, with someone else in the future. But she has certainly an additional option in her narrative that was not present before. And there is a new meaning and new connections that she can make now to that because of it.
If you tried to force the new narrative in without softening, backing up, connecting in this deeper way, and connecting with a sense of self that you get from perspective taking that is more able to open up to new ways of thinking and to direct attention in new ways, I think you would have just, ended up either in an argument or in her feeling invalidated or not understood. If you were me, you wouldn't ask me to do that. Don't be telling me that I can just sort of change the meaning of this pain. I mean, I should never, how could I possibly, and all the rest.
Who in their right mind would want to accept this pain and go deeper into it? Just remove it. Of course, no one wants to feel this level of pain, but instead, I think what we were able to do together in that moment was help her to see. But there was no way out of than death, and her daughter was there too, and that new connection there, not to the death and the pain, but to being present with her daughter, and that was worth it.
The first word in ACT is acceptance. What's inside acceptance, the way we mean it, is not tolerance or resignation or putting up, but it's nothing like what people are told by people around them, well-meaning but invalidating. You just need to accept it. It's nothing like that. The original root of the word meant to receive as if to receive a gift. And we actually still use it in English. We say, here, when you give a precious gift to somebody, will you accept this? Why do we say that? We don't say, will you tolerate this gift? Will you resign yourself to seeing this gift? That's not what you mean. You mean, will you willingly take in what I'm offering to you here? This is so precious. I want you to choose to take it. I'm offering it. Yeah. Well, there was a precious gift in the pain here. It's the love she has for her child. I mean, it's one thing. Love and loss is one thing. And if you just say those words, it wouldn't mean anything, but we connect to it from the perspective of her daughter. You sort of see, my tears were a gift in this, my fear even. Well, in the same way, here's what I sometimes say to folks when they come to me and say, I just want to get rid of this anxiety. I want to get rid of this sadness. I want to get this depression. I say, okay, you got kids? Are you going to have kids? Yes. Okay, here's the deal I'll make with you. I will remove this anxiety 100%. But here's the deal. When your children come to you and say that they're afraid, when they come to you and say that they're sad, you will have absolutely no idea what they're talking about. It'll be like they're from Mars. You're going to make this deal? And, I've never met a parent who wants to make that deal. Magically, they want to know about fear without feeling fear. They want to know about sadness and be able to give that to the people that they love without knowing about sadness. It doesn't come that way, dude. The reason that we can be there for our kids is that we're whole human beings and we've been there ourselves. Yeah. So, and there's an example. What is the precious gift? It's just like physical pain. Do you really want to be a leper? Do you really want to have feeling in your fingers? What'll happen is it'll get, people literally, not just from the necrosis, but they will accidentally put their fingers in a fire and not remove their fingers. Feelings, you wouldn't do that physically. I'll just remove all physical pain. That is a medical condition that's going to create physical damage to you. It's the same thing psychologically. Mm-hmm. You're not going to be able to negotiate a whole human life, but you're also not going to be able to be there for others.
A couple things that I do because it does sound so harsh, and if they miss the initial point of you got to tell someone to accept things, of course that doesn't go well at all with clients or patients, because you're not actually working the processes by forcing them to just say something's good. So I use the analogy, I may have gotten it from one of the books or the trainings, but you talked about the gift, and I talk about holding the gift. Rather than saying this is good, I just talk about holding it, realizing you have the other hand to do something while you're holding it. And then the other thing that I've used in training residents is one of the exercises from Self as Context. We talk about the I am exercise, and we take a minute or two and write all the words you can come up with. And if I have to feed them a couple of domains, like relational domains, I am, I am a wife, I am a husband, I am a friend, I am this. And then you might give them, different roles that they've had. You might give them different diagnoses or symptom clusters. And so they end up writing all kinds of things in 1 to 2 minutes. It's done different ways. And you look down, and when you first look at it, of course, you're seeing all these words. I am depressed. I am a resident. I am underpaid. Who knows what's on the page. And then, of course, I have them draw now a frame around that. And I am is in the frame. And all of the words are inside the inner box. And then I'm a little direct and harsh at times, but I say you've lied to yourself. You are none of these things. You are the you that notices that sometimes some of these words apply to you. You are the you that can decide if you want to change some of these. You can quit being a resident today. I don't advise it with your med school loans, but you could do it. You could get out of a relationship. You could add a new relationship. You are the you. You are not depressed. You are the you that notices that sometimes you have thoughts about depression. And of course, you could speak more to the processes that occur there, but there's emotional distancing that's occurring, and then the self as context rather than self as content that's occurring. And I find that those two exercises, I think, get the conversation going, because it's powerful when they realize they're not defined by the words they've been calling themselves.
Yeah, you are the one observing what you put in or take out of the box is what I sort of.
Yeah, exactly.
see.
And then, in our wisdom traditions, our spiritual traditions, they all have practices that help people find this sort of deeper sense of self that's just awareness, pure awareness, period, end of story. When you say that word, it doesn't mean much of anything, but we're living inside this all the time. I mean, there's a part of us that is noticing what we notice. If you have a physical pain, the pain didn't notice itself. An organism, a being called you, noticed it. A conscious being, an aware being. And so from that perspective or point of view, many, many things are possible. And acceptance is simply to take in, to receive the gift, to say yes. I have a little exercise I do, and people listening to me right now could easily do it. If you want to sense what acceptance is like, just look around the room, and everything you see, say no, and find something you can criticize about it. Oh, that's a cheesy clock. You spent all of $15 on that one, or whatever. Look at how dirty this is. Look how badly that's designed. And then feel what it feels like to be yourself, looking at these things around you. Don't do it to human beings, by the way. It's not kind. And say no to them. Well, then do the same thing. Now, flip it around and say yes. Yes, it's just like that. Yes, it has a function. Yes, at least it's still working. Yes, old friend clock that's been there for perhaps too many years. Yes, familiar object. Is find a way to say yes, not just judging it positively, but being open to the experience of that object being just like that and you connecting with it. And when you do that, you have a sense of a fog lifting or a space opening up. You can feel it literally in your body. If you actually do biological measures, you are changing things all the way down to epigenetic regulation of stress-related gene systems. That 5 minutes of this kind of meditation will up and down regulate something like about 1% of your genes through epigenetic processes. That's study's been done. Herb Benson at Harvard did it. It's very rapid. It's literally happening right now. But so could you say yes to your own experience? Mm-hmm. Is your own experience your enemy? If it is, you better learn how to run at light speed and break out of this universe into some other one, because your experience is following you, dude. It's with you right now. So could we do something that's kinder, more self-validating? It gives you a foundation, a place to start from. I don't know how to start from where I'm not, but I do know how to start here. And my experience right now is this. When I say yes to it, it doesn't mean I like it, doesn't mean I want it, doesn't mean it's going to persist. It doesn't mean I got up in the morning saying, hey, I want to have anxiety today. It just means, yes, I feel it like that. Now, what am I going to do with that? Well, I don't know. What do you want to be doing with that? There's lots of different things you can do with your experiences. And so, yeah, that habit of being here whole and free is something you can inculcate in yourself and with your clients, and it empowers human life.
Could we maybe just pick one example and walk through all 6 of the processes, just for those who haven't? Because I definitely haven't used ACT before.
Yeah, can I pick the example?
Sure.
Which I know a lot of people who listen to this are people in training.
Yeah.
And one of the things that people in training have is like imposter syndrome.
Sure.
So let's say I'm one of those people, and I feel, as I go along my work, I'm not good enough. I don't know enough. I'm not doing what I'm doing well enough. And maybe I'm even listening to this episode and I'm thinking, I have no idea a lot of these things. I'm not doing any of that. I'm an imposter. I'm not good enough or smart enough, or, like all of those things.
Okay. Well, so I would, let's walk around. And so I'm going to suggest micro exercises to do with an imposter syndrome. So let's start out just with the thought, I'm an imposter, and allow that to sort of get that clear in your mind. And I would ask you, how close is that thought to you when it's showing up? Show me physically, like show me with your hand. Is it up here when it shows up really close to you, or is it out there? If it's up here, it's very difficult to see what's around you if that hand's right in front of you. If you can put it out a little bit, you can have that thought and still be able to see other things. So how would you be willing to sort of do something that would help put it out there? And let me give you an example of something you might do. I want you simply to say that thought to yourself in the voice of your least favorite politician. Or pick a cartoon character. Just do it. Or sing it to the tune of Happy Birthday. Just do it. Okay, so you've got that thought. It can land in different ways. I'm not meaning for it to go away. Now, I'd ask you to imagine that your life has unfolded in a powerful way, and you're looking back at this point in your training where you felt like you were an imposter. Let's take this out. It's 10 years from now, and you've given your whole effort into your training. You've really focused on what you came here to do in terms of serving your clients. And you're looking back at yourself sitting here right now with that almost hand right up in front of your eyes saying, I'm an imposter. And from that perspective or point of view, actually take the time to put yourself out there. What might you say to yourself about how to be with yourself with that thought in a way that doesn't interfere with what you came here to do? What advice would you give yourself?
Maybe
whatever a person says. Do you have one that comes to mind? What you might say?
Don't be so hard on yourself. You're trying the best you can.
Okay. And so let's come back in your body now with this, don't be so hard on yourself. We've done our little singing of the I'm an imposter. So take the part, what shows up.
Neil, can you do the singing for us? Can you give us, what would that sound like? No?
No singing.
No? Okay.
Well, I'd like you to do this. Let's create that thought, I'm an imposter, on purpose, but now coming back with the don't be so hard on yourself. And I want you to watch what your body does when you have that thought. What shows up? Do you clench your jaw? Do you clench your fist? Do you tighten your stomach? What if we were to apply don't be so hard to yourself on that moment? Is there anything else you could do with your body when you notice that? I don't mean that you have to change it necessarily, but can we just notice that one of the things shows up is that you tense it almost as if, isn't it true that you're going to have to defend yourself?
Mm-hmm.
Do you need to be hard on yourself in that way? Like what would happen if this is something that it's okay to have? You're learning something new. It's a challenge. You have a thought, I'm an imposter. And part of it is this physical feeling. How would we even know that we're touching into this space? Can you I ask you this question? What emotion shows up in association with I'm an imposter? We know a little bit about the bodily sensations. What emotion shows up?
Probably more fear, like this image of running naked on a football field with a football and people are chasing you.
Awesome.
I had that dream years ago.
Awesome. And so you know that you've been dealing with fear and with this sense of inadequacy and shame or whatever, the running naked, I've imposed maybe even that as if. And so could I ask you this? Would you be willing to sort of feel that fear? If you could meet yourself at a younger age where you had that fear, you're going to be running naked down the football field. How old were you?
When I think I was a third year resident. Yeah. So
okay.
that was what, about 10 years ago.
So here, I give you a little option here. Would you be willing to sort of feel what it felt like then to have that fear, but to do it with a posture of self-kindness, of not being so hard on yourself, of maybe even kind of allying with yourself, sort of the way you might if you were sharing with a friend what it's like to feel fear.
Mm.
Is fear your enemy? Have there ever been times when fear has been helpful to you?
No, I think fear has served me sometimes. When I was rowing, I rowed for Cal Bears, and a little bit of fear at times would make you pull harder.
Okay,
help you
awesome.
Accomplish the goal.
Awesome. And so could we do something with that fear that would more fit into your experience, that there are times where fear has sort of helped you? So let's just take the fear of a posture. Let's just sort of bring it on board. And then my question to you would be, what would you want to do in your training with that fear that would serve the people you came to serve? Like, what is your training about? What
Helping people.
What is it in the service of? What do you hope to accomplish with your training?
Maybe I could use that fear to buy some more books.
Okay.
To read some more books to prepare
and if you don't,
to prepare to help people more.
Okay, awesome. So if it's not to get rid of the fear, but it's to prepare, and what is that to prepare to do? What do you want to do?
I think if I know more, then maybe I'll be able to help people more.
What kind of help do you want to be to them?
I want to be able to hear their story, and after half an hour, be able to maybe make changes to their medications or be able to guide them in therapy in a way that would actually be helpful.
And if your next client comes to you and says, I fear that I'm an imposter, and it hits me so hard that it like freezes me in place, would you be willing to take in that fear if it helps you sort of put yourself into the perspective of the next client you're going to see?
Yeah. Maybe I could feel to some degree what I had felt and feel some of their fear.
Yeah.
And it might be able to help them. Is that
Could you imagine even sharing that story? If it was apt, you don't have to necessarily self-disclose, but could you imagine that maybe even sharing that story would be of use to your client?
Yeah, I mean, I hope if someone's listening to this right now, even though they're not in the room with me, maybe they hear parts of my story. Maybe that helps them. And that makes me feel good, thinking that we might be able to decrease collectively the fear of many people who might also have this sort of same conflict.
Yeah, because isn't it so that we run around with these secrets of these, I'm an imposter, people will see it, they'll see me naked, right? That metaphor.
Yeah.
And what if the big joke is we're all walking around with the same freaking secrets?
You know, what's funny is after I became an attending and I started seeing medical student after medical student, resident after resident, I realized that was true. That I was like, wait, I went through medical school and I had some of these feelings, but why didn't anyone ever talk about it?
And so out of that value of helping people, but you also have a value of being a trainer, yeah? Would if you see something in there, is there something of importance to softening, for example, the training environment in which we create an environment where we get to share even some of these fears and do some healthy things with them in the interest of the clients that we serve, but also in the interest of the learning that we have to do?
Mm-hmm.
Like, is that of importance to you as a trainer, to be the kind of person who could share some of those stories and put yourself inside their skin? And so I have a final question. Would you be willing to sort of think of some concrete thing you might do over the next week that with your clients and with your trainees would give form and substance to this idea that you're willing to notice your thoughts and not buy into them, and to notice the emotional reactions they have, and even what happens in the moment with your own body, and maybe be able to create a softer environment where people can have experiences like that and not have to enter into a cul-de-sac of hiding or of struggling or of trying to eliminate and before they can move on. To create a world where it's okay to be a human that has things like that happen to them.
Mm-hmm. Yeah, I'm thinking of a committed action that I could take of today we'll do continuous case conference with the residents, third years and fourth years, and we'll watch them doing psychotherapy. And so maybe I could find some increased empathy into the experience of the resident who's doing the therapy. It's always a nerve-wracking thing to put yourself out there, let other people see what you're doing.
Awesome. Well, so the 6 processes are in this conversation. We started out with a little bit of diffusion, trying to just take the thought and be able to just notice it when it's so loud and dictating, but then we came into the present moment, but then we kind of connected with values, and then we did some perspective taking, and then we opened up a little more emotionally, and then we looped back over into what commitments you might make out of the values. So we're dancing around this hexagon of these opening processes of acceptance and diffusion, these centering processes of the moment, attention to the now, from this part of you that can move consciousness around time, place, and person, like going out to the distant future or going in behind the eyes of your trainees or your clients, and then finding what you want to reflect in your behavior, the intrinsic qualities you want to put out in the world, those are the values, and then committing to doing that. So this is just a conversation. We weren't really trying to do elaborated clinical work. But I find these conversational things quite important with myself and with the people I love, just everywhere.
I think it solidifies as well, kind of like some of these more theoretical things. I think I like to make it more concrete because I imagine not all people are high ideation as myself, right? So I think it's good to bring it concrete And we'll write this all down in the article we'll put on the website psychiatrypodcast.com if you want to check that out. And we'll go
Awesome.
we'll put it there so people can go through it. They can see your hexagon of
what's helpful about it for early career and trainees is that it is 6 processes. They're all interconnected, and you have certain leanings and you have certain tendencies that you're going to be good at, and you might pick up on those earlier. But then knowing that these other processes are there, you will also find things that will be beneficial for your clients and patients that you may need some reminders to work a little harder on. In the ACT circles, they talk about left-sided and right-sided clinicians. I'm a right-sided clinician, which means, I do great on taking the next step, and I do great on helping them find their values. But I need to work a little harder to not forget, keeping them in the present moment and the bodily sensations work. But what's been so helpful is that the model includes these other things that I am naturally good at and that I naturally need reminders of to pursue. And what's amazing is those things that didn't come as natural to me in my training end up being often more beneficial than my initial intuition for them, because I do try to work towards all processes as they show up in the session, those stuck moments, those inflexibility processes, and then you catch which one they're not flexible on, and that's the one you pause and do work on it, and then you move on. Yeah, and so for me, again, as a conceptual model, as a trainee, and then moving into being an attending, it was helpful to learn it, but it was also helpful to correct the deficiencies in my intuition.
Yeah, they form a whole set, and some of us are naturally better at one versus the other. Some clients come in with skills in one area and not the other. And that's the kind of personalized medicine kind of quality of it. Some people are really good at making values choices and following through, for example, with behavioral commitments and so forth. We're really not so good at being able to be emotionally open or take the perspective of others. And so when the model fits together and supports each other, that's an empirical fact. We've actually done randomized trials with only the left and right comes from the hexagon. The left ones are the acceptance and diffusion, center ones, self as context or perspective taking in the now, and then values and committed action on the right. And we've done randomized trials with only the center and the left, or only the center and the right, and all together is better. And you can predict at the level of processes of change, the ones you target, the ones that change, and you can predict what's going to happen in terms of problems. If you work only on the left, people might not yet get around to actually putting it into a word behavior change so readily. If you work only on that and on values, sooner or later you hit something where you don't know how to open up or step back or notice. And so then progress stops. So you need all 6, and by having them, it kind of bumps you out of your comfort zone. A model is only needed when you're not fully in the flow and everything's working. If what you already know how to do is working, just do that. But when things are not working, you need a model, because it's going to push you out into areas you need to learn. And that's going to be outside your comfort zone.
I'm wondering, also, sometimes you refer to ACT as a third wave. And I don't know if I do this right, but when I talk with trainees, I talk about, the water being kind of everything we inherited from our wisdom traditions and religious traditions and Freud and all the stuff that happened. And then the first wave is behaviorism, and the second wave is the cognitive move, and then the third wave is ACT and some other things. And I wonder, what is so third wave about it? What's so process about it? What is there to learn from the next step coming, whether it's ACT or contextualized schema therapy or process-oriented CBT, or what's coming in? What do we need to learn regardless of our current training? Maybe we've only learned CBT, maybe we've only learned some other types of therapy. So what's third wave, what's process, and how does it relate to these other areas?
Yeah, third wave is a term I used back in 2004 because I noticed that acceptance, mindfulness, all these kinds of things were coming in. And they all, instead of trying to change the content, were trying to change your relationship to content, which many of the deeper clinical traditions had already had, really. But inside the CBT tradition and mainstream evidence-based therapy, not so much. I think it's outliving its usefulness because I think the whole field has kind of gotten on board with regard to that. I don't know if I want to use the wave metaphor, but I do think, and you can see it with RDoC and what was happening with NIMH and so forth. I do think evidence-based care, it needs a different model, and we're going to have to go from protocols for syndromes to something new. And the attempt to try to do the RDoC experiment that Tom Insel did was an attempt to get to processes that would link to the developmental neurobiology that was assumed to underlie mental illness. I think we need a broader, a little more Catholic, small c perspective that is open to any of these processes. Some of them are maybe sociocultural things, and some of them are psychological things. Some of them are neurobiological things. Some of them may be epigenetic, genetic kinds of things. I mean, we need one whole biological organism that's also psychological and part of a social cultural group. So I do think where we're headed is more idiographic, personalized, and process-based. I think that's true in mainstream medicine, and I think it's true in psychiatry and psychology. And it turns out we've got quite a bit of pretty good leads as to where we can go. And once we direct Western science towards that, I just think we're going to make a lot more progress because we're just on the cusp of how far can you go. I mean, I love these studies, for example, that look at what happens neurobiologically when these acceptance and diffusion processes are put into a client. And there's some really good evidence that it changes how information is even processed by the brain in a very fundamental way. And so in all of these different disciplines and these different theories, let's get out of the school-based thing. Let's focus on tools that you can use that are linked to processes of change that matter and see how far Western science can walk us forward on that in a way that applies to the individuals and couples and families. I don't mean individuals, I mean the particular focus of our clinical work. And it's not, I don't think it's way off in the distance. I think it's right here, right now. It's happening. It's going to look a little different. It's going to look a little different from what we've done.
Can I ask you, so there's this other school of thought to look at in between therapists, like effect sizes,
Yeah.
There's a recent book that we did an episode on, Better Practice, or, and talk about it's really about the therapist getting some feedback. Like there's the outcome ratings scale, and then looking at them and how they personally are doing in terms of are they giving empathy and, did the patient feel heard and understood? Did the patient feel like they were working on things that they wanted to? So this kind of outcome measure, and then using that outcome measure to kind of coach yourself and being coached. And what I've seen in a lot of therapy schools is there's some therapists that just do better than other therapists,
Yeah.
And so I'm curious, how you see that in ACT. Have you ever looked at, one ACT therapist versus another? Is one doing better than the other? And then what are they doing differently? Do you have any thoughts on that type of?
I do. And what these kind of Common Core process perspectives orient towards is the centrality of the relationship and so forth. And I think that's very important. Although there are apps and websites and things that have reliable effects. So it isn't just the social relationship. I mean, you can show that some change methods can be put in contexts that remove that and still have a big impact. But what I don't like is not being told exactly how to get there, because a lot of these models work when you do correlational studies of therapist factors and ratings of it. I can tell you in the study of mediational outcomes, the Therapeutic Alliance, for example, rarely functions as a mediator. And the only way that that can work is that it means we don't know in the arms of these randomized trials how to get better therapeutic alliances. If we did, and it's important, then it would function as a mediator. There's only 5 studies we can find where that was true. There's a vast literature on it, but it's correlational. It's not controlled and functional. But I don't want to blow up the importance of the topic, because some of the few studies that have showed this, some of them are ACT studies. And we've done things like put in multiple mediator models, the therapeutic alliance or psychological flexibility changes of clients. And here's what happens. Therapeutic alliance mediates outcomes. If you put in the psychological flexibility changes of the clients, it eliminates the variance due to the relationship. And now that's the thing that mediates outcomes. Here's why. If you understand it, you won't freak out. If you really care about the therapeutic relationship, here's why. The therapeutic alliance, the therapeutic relationship works because good therapy models acceptance, non-judgment, conscious attention in the now from another caring human being where your values matter and we'll work together to get things done that you came to do. Those are the 6 flexibility processes. And you know that, because if I asked you to pick somebody in your life who lifted you up powerfully, just pick up anybody who really was a powerful, empowering person in your life, and I asked you these questions. When you're with them, did you feel accepted for who you are? Were you constantly being judged, or was that somehow far away? Mm-hmm. Were they looking at their watch, or were they looking at you? Were they with you? And did you have a sense when your eyes met that your 2 conscious human beings were together? Mm-hmm. Would they ride over your values without a second thought, or did what you care about matter? Or was it always one way, or my way, or the highway? Was it always up to them, or did what you care about matter? And could you be together in ways that fit the opportunities of the situation?
Right.
I can give you the answer to your questions, and I haven't heard you say anything. I know what you said. You just gave me 6 yeses.
Yep.
Those are the 6 flexibility processes. So here's the deal. The reason why you're empowered by people is because they model flexibility processes, because those are the processes that most empower people. So why can't we do that? We come in as a therapist, accepting, non-judgmental, conscious, from this kind of core awareness of 2 human beings interacting consciously, where their clients' values and your values are in the room, and that we can be together in ways that serve the goals and interests that we have. So what happens when you teach flexibility skills to therapists is their working alliances go up. Their therapeutic alliances go up. Okay. Because they start putting it into their moments of interactions with their family, with their friends, with their clients, and with themselves.
Yep.
And so I think it's important, but I don't want to be left. I actually do a thing with when I'm doing workshops that say, how many people in here think the therapeutic relationship is really important? 95% of the therapists quickly raise their hand. How many people in here think you do a pretty good job of establishing effective therapeutic relationships? 95% of the therapists raise their hand. And I say, how many people in here think you live in therapeutic Lake Wobegon where all the therapists are above average? Mm-hmm. And then the people titter because half the therapists are below average. Hello. Yep. It's a mathematical requirement. And guess what? Those are the ones that aren't having good outcomes, but they're in the workshop raising their hands.
Yep.
Unless only, really cool therapists come and do trainings with me, which maybe could be true, but I don't think it's that true. So give me a way out of unknowingly being in the group that cares about the alliance, cares about the relationship, and is accidentally fostering dependence, accidentally, rescuing clients. I mean, you can care and be bad at something. And you probably know clinicians who are like that. You wouldn't want to send your clients to them, but boy, do they have a bleeding heart, man. They just care about the alliance, blah, blah, blah. But they're never coming off their client list. They're going to be on there forever. I bet you know a clinician like that. I do. And you don't want to send your friends and family to them. So I like the spirit of it, and I think it's actually true. But I want to be able to train clinicians so that they get in the really high group and out of the low group.
Yeah, and I think here's what I'm hearing from you. Therapeutic alliance, of course, is important. But after I've read all these studies on the importance of it, it's not clear what actually you can do to increase it. And the studies that are attempting to increase it don't always work out well.
Yeah.
And so what you're saying is, hey, here are some things that are probably going to mediate that impact. And, I feel it from you. I mean, I feel from this conversation, like, I feel like your attention, your connection, your non-judgmentalness, it's evident to me. And so, let's target these 6 things. Let's see where you're weakened, and let's see what we can improve.
And then adding in feedback informed stuff, of course, that's great. But if you just have that, well, then variation selection is what you're hoping for. But, variation might not include the kind of variation you really need as a person to be a therapist who will really move that client. Let's use Western science to say, what are the processes? And those processes are embodied by the therapist. We know this, the psychological flexibility literature shows that kids, for example, if there's some sort of school shooting or something horrible, the kids who develop PTSD are the ones who have parents who are inflexible because it's being modeled to them. The same thing with therapy. So, yeah. Let's work on ourselves. Let's put it into the space and the betweenness with our clients.
Yep.
And let's work with our clients. But don't forget that we're modeling in the Therapeutic Alliance processes. And let's make sure that they're good ones, and they're not just things like getting people to come back because they're dependent on you, or getting people to try things because they believe in you. I mean, a lot of those things can blow up.
Yep.
How about believing in themselves?
I want to hear from the my medical students here if they have any questions or thoughts as we kind of wrap up here. Maddie, do you have any thoughts, Matt?
I liked the example of imposter syndrome. I think I have those kinds of feelings every once in a while. And I'm grateful to be exposed to all this stuff. And it just really fostered an interest of diving deeper into these different types of therapies. So thanks for coming on.
Well, and thank you for modeling that openness by sharing that. And by the way, imposter syndrome, big time in my head. Not so much, I have to admit, the older I get, it kind of drops away. I guess I just don't care anymore. But it's not that it's not there. I can certainly find it. But yeah, and that just indicates that you're human and you care. And I think it kind of comes with the territory. Am I good enough? I don't know. Let's find out.
Maddie, what about you? Here you go.
I probably have too many questions. But one I have is, because I know you talked about a little bit before how you can use ACT more in a social context to promote change. So I was just wondering, what would that look like if it worked the way you wanted it to? Because there's so many things going on today where we could all use a little bit more acceptance and openness, like with Black Lives Matter and all the LGBTQ.
Absolutely. Well, and there's about 4 or 5 randomized trials of ACT for stigma and prejudice of all kinds. Maybe more than that, actually, if I expand it out, because some of it, if you look just at racial prejudice, I think there's 2 or 3, but then you look at, the sexual minorities or gender issues. And what we found, actually, if you just take that issue of prejudice as an example, that it's predicted by failure to take the perspective of the other person, failure to connect with the emotional responses that come when you do, and unwillingness to sit with it when it's hard. Those 3 things will predict the objectification and dehumanization of others in every area we've measured. Whether it's you have a weight issue or a substance use issue, a mental health issue, gender, religious minorities, sexual minorities, racial minorities, language differences. In every area we've looked, there's this core, and it's predicted by these flexibility processes. And if you can change them, it alleviates it. So we've put it into things like the World Health Organization recently did a randomized trial of ACT with South Sudanese refugees who are in Uganda. with a self-help program that consisted, because most of these folks are not literate, of a cartoon book and an audio tape. It was published in Lancet Global Health, a pretty high-level medical journal. And if you go to the World Health Organization site right now, they didn't have anything for the stress of COVID, and they put up the ACT self-help program. If you're stressed about COVID, you can go, and WHO will tell you can download the cartoon book and the audio tape, because it's been, why? Because they showed even in that kind of a challenged world where people had escaped from violence with nothing but their children and the clothing on their back, and they're sitting in dirt, that you could get effect sizes as large as you get for self-help in the developed Western world. That was the benchmark they set for success. So that now they're saying, well, geez, if it's that broad, well, COVID is really stressful to you, try this. It's probably helpful. So we've put it into interventions. The one that, if I can just mention, that is a social transformation change is an intervention we call pro-social, which takes ACT and then mixes it in with Elinor Ostrom's Nobel Prize-winning core design principles. Lynn Ostrom, she's dead now, but I spent time with her. And my colleague David Sloan Wilson, who's an evolutionary biologist, showed that indigenous peoples can protect their forests, lakes, rivers, and streams, but only if they organize their groups in an evolutionarily sensible way. And we're looking around the world at the failure of command and control economies or bottom-up invisible hand economies. They're both failures. But there's a middle path, which is the way humans actually work. The model of human beings that are in either command and control or invisible hand is a lie. We are not inherently greedy, and we don't like being told what to do. But we do like working with our mates. We're the social primates. That's how we evolved. And if you can build a different culture around that. And so the book is called Pro-Social. It's entering into small groups and organizations around the world. There's a large group of trainers. And so it's that spirit of let's put psychological flexibility where it's needed. We can put it in our diversity training. We're going to do it anyway. If you're on a hiring committee, you have to do your diversity training. We've shown that we can actually move some of these stigmatizing processes, even with implicit measures. But let's put it also in softening some of these conflicts between peoples and finding a way to go into the refugee camps or to deal with some of these, what do we do with immigration? What are we going to do with what climate change is going to do? And a vast number of people are going to have to move or die. And you look forward, we have a train wreck coming if we can't figure out how to work together with others and think about this as one group called human beings in one world, the planet itself, and find a way to support each other in rising to these challenges. So psychological flexibility will be part of it, and we're kind of out at the edge trying to figure out how to put it into this more communitarian and social level of intervention.
That's good.
But you can check out the World Health Organization publication as a start. We did, I've gone on, but we took pro-social and we put it, for example, in Sierra Leone with the Ebola crisis. And we did ACT plus pro-social, and where we put it was in the city of Bo, which had an ACT clinic. It was one of only 2 clinics in the entire country. And 1 psychiatrist, 1 psychologist, and 6.5 million people, Sierra Leone. And we were able to deflect that Ebola outbreak at the height of the thing 2 summers ago better than any other district in Sierra Leone. And what did they come up with? Like, can I have time just to tell a quick story, 2-minute story? Am I good?
You can keep talking. Yeah, we're loving it. We're loving it. It's good.
What we did was we went in, we did these ACT workshops using a thing called the matrix, which orients you to a really quick way of what do you want to move towards, what happens inside you move away, what does that look like on the outside if you move away, what would it look like on the outside if you move towards. This matrix training combined with Lynn Ostrom's design principles. And in a group of, literally, I have a picture of it, 500 people under a concrete roof in a village, somebody proposed, here's what we should do. Remember, these are folks who don't even understand the germ theory of disease. They hacked health workers into pieces with machetes because they thought the people coming in with moon suits were bringing the infection.
Oh, no.
You remember these stories. This is Sierra Leone. And somebody said, what we should do, they have these rituals. You have to pray over, kiss, and wash the bodies of the dead in order to pass them on to the half-life, to the next life properly, right? And here they have people saying, no, we have to take people who are sick and carry them away. And if they already died, put them in plastic bags and burn them. Well, that's a sacrilege. And what they came up with, I have a blog I wrote called Kiss the Banana Trunk, was this idea of they would cut down banana trunks because there were banana trees everywhere in Sierra Leone. And they would wash, do the rituals, wrap it in a clean sheet and bury it. And that ritual spread through the Bow district. And I have a picture in this blog of a woman carrying 3 wrapped banana trunks. That's her husband and her 2 children. And she's walking to bury them, having prayed over them. There's a picture of the church where they did the rituals, and there's a mound of about 30 banana trunks, each neatly wrapped in a white sheet. So, the West would never come up with that. Their idea was doctors with guns. They got the doctors who cared and the military with them, and they would hold guns at people and say, give me your sick relatives or we'll shoot you. And it stopped the infection. But in Sierra Leone, in the areas where they did that, domestic violence is like 2 or 3 times high what it was before. They ripped the culture in shreds. What the people who came up with the banana ritual called it was a reparation ceremony, because it was a ceremony of repair for the damage that they were doing to their culture and to their love, to their traditions. So I don't know. I mean, let's not sell human beings short. Could we give them tools they can use and processes that matter and get in there and step up to these challenges of racism and poverty and immigration? And if we don't, and climate change and all the rest, if we don't, I don't know how we're going to have a world that's livable for our children or our children's children.
All right. I want to give Matt a chance here to ask a question.
I just want to thank you very much for your time, Dr. Hayes. It's been fascinating hearing you speak. Enjoyed your articles talking about some of the similarities between Buddhism and ACT, as well as spirituality in general, and maybe building off of your answer to Maddie's question, I'm wondering if there are any specific sticking points you've found in integrating ACT into more of a Western worldview. Are there certain points that people are very resistant on when they see some of the similarities applied to a Western point of view?
Well, ACT resonates with all the wisdom traditions, not just Buddhism. I mean, every single major spiritual and religious tradition has a mystical wing, and they all mess around with literal, analytical, judgmental language. They all do, whether it's silence. I mean, Christian monks, they're doing silence, whether it's repeated prayer, saying the rosary, saying, ejaculations, etc. The Catholic tradition I was raised in. So I think the B word has actually been a problem, because while it's true in the East, some of these processes are there. And as an ex-hippie, I knew about some of those things more from the Hindu wing, actually, because my individual history of just people I happen to run into, although I ran into people like Joseph Sasaki Roshi, the now dead famous Zen master and so forth, as a 20-year-old. In California, but I think it's actually narrowed the impact, because you don't want to walk into South Carolina and start talking about Buddhism. I mean, nothing bad about South Carolina, but I lived in the Carolinas, and you'll be shown the door very quickly, because the ministers have explained how dangerous this is, and so let's find a way to be more universal in how we discuss these things. And it's fine to learn from wisdom traditions and read Buddhist texts if you want to. But that's not where ACT came from. And I think we can put it into Western science. And not only that, you can put it into cultural wings that are not evident. I'll give you an example. We do ACT-based safety training with people like Boilermakers. They have to go down inside these big machines and so forth and wear hard hats. And if a tool gets dropped from above, they might die, and so safety matters, but they're pretty tough, and the idea of wearing a safety belt and putting, come on here. Okay, so here's what mindfulness is in the work that we're doing with ACT for Boilermakers, situational awareness. And everything you want to talk about with mindfulness, you can talk about in that language. Mm-hmm, mm-hmm. And I've got pictures of Boilermakers who had printed themselves the little ACT hexagon and glued it on the front of their hard hats. And why? Because here's the values-based thing. I want to be there to watch my kids' graduation. It's not about some grand hoity-toity thing. But can we put things into normal people's lives? Yeah, we can. And let's find a way to language about that in a way that fits the culture or the traditions. So culture adaptation doesn't just mean, a collectivist culture. You have to talk about things in a collectivist way. No, it might mean talking to a person who doesn't have a high school education. When we're doing mindfulness work with them, we have images and quotes from cage fighters who, by the way, do meditation. Or shock jocks. Who's that famous shock jock who's a meditator? I'm blocking on his name. Howard Stern. He's a meditator. If I'm going in and I'm talking to folks, real, like, blue collar folks, I don't want to be putting up the Dalai freaking Lama. I'll show them a cage fighter and Howard Stern.
Yeah.
So let's, I don't think we need all this full woo-woo wraparound. I'm not meaning that in a disrespectful way. I hope I'm not heard to mean that we want to kind of say anything disrespectful about our spiritual wisdom traditions. I'm just saying the essence is more important than the form.
Yeah.
And get it into people's their hearts, their heads, and their hands. Whatever language does that, I'm down with that.
Hey, this has been true. This has been really good. Can I have you back, Dr. Hayes, for another part 2?
Awesome.
We'll do some more, like, I think the little examples really bring home these points, and this has been truly wonderful. I've been blessed by it. I think my listeners will have been grateful to have heard your wisdom and your experience. And I think some of the things that you were doing very quickly. And so we'll write that out and slow it down for the written portion. And if you re-listen to it, you could probably get it again and sort of let it sink in. And it's been a pleasure. And we'll
and if I could just say, if people find there's something in here that resonates, of course, they can go to my website. You'll probably put it up there. It's just my name.com, StephenCHayes.com. And I'll send them a little 7 mini lesson for free. I don't spam people. It's a one-click opt-out. But I do send my newsletters. But also the ACT community has a tradition of giving away and really kind of making barriers low. So if you're interested, you'll find just out on the web a lot of resources that are there. The society that Association for Contextual Behavioral Science, which has a really good, by the way, psychiatry special interest group, is, we charge values-based dues. Pay what you think it's worth based on your ability to pay. As long as it's $12 cool. Because we give all that to Elsevier for the journal, which then comes for free. So there's really low barriers to get in there and learn these things and to see the tapes. And so if it's something that resonates, follow it. I've watched what happens. If something connects and people follow it, they get good. They learn how. And I don't think Neil is the only one. It becomes useful very fast.
Yeah, 100%. I'll have all your links on my website and in the show notes. I'll put some of those up as well. And it's been a pleasure. And, if any of you want to get some free CME, I'll put that up on my website in the free CME section on psychiatrypodcast.com. And I will be more than happy to collaborate with you in the future. And it's been a real pleasure.
Thanks, David. Thanks, Neil. And thanks to your students.